Hi, good afternoon. Can you see us? Can you hear us?
Yes.
Yes, Rajesh, Dr. Panja here. And with
Hi,
me,
sir.
three
Good
friends is
afternoon.
with me. Yeah.
So, welcome to the Department of Cardiology, PGI Chandigarh. It's a privilege and honor to have the live case there, the NIC CSI. Thanks to the organizer and the Pratap for the favor. So this particular case, let me introduce my team. Dr. Basant is associate professor working with me, and Dr. Jai, senior resident, Dr. Thakur, and Dr. Tanuja is also there with me as the fellow of cardiology. I do have the Joseph as the technician, and Nikhil is there on the imaging. So can I have the PowerPoint presentation? Okay, Dr. Basant, next slide please.
So here is the case. 81-year-old hypertensive male presented with angina, rest angina a week back. The clinical examination was unremarkable and ECG was showing, you can see here, RBBB and TROP-T was positive. Creatinine was 1.14 milligram per deciliter and EGFR was 62 ml per minute, 1.73 meter square. So see, he has a significant past history of PCI, distal RCA and proximal LCX was done in 2009 at another hospital, and the PCI to the proximal RCA and the distal LCX in 2016 in our hospital. Next slide, please. You can see the echocardiogram is a well-preserved LV and the concentric LVH, normal EF. Next slide, please. So here is the angiogram. You can see this view, the ostial LCX has a significant lesion, and the proximal mid LAD has also significant lesion. Next view, please. Yeah, the mid LAD has a significant calcified lesion starting from the proximal one. In the caudal view also, it is the same. Next view. So RCA patent was a stent. Next view. So PCI to RCA was done in 2016, next slide. Yeah. So PCI, the distal LC in 2016, where with the rota ablations, 1.5 mm burr and 3.38 Giants prime was implanted. Next, please. So the plan is the image-guided PCI to the ostial LCX and the LAD. Over to you.
So,
Can you show the
Rajesh, this is
yes.
Rajiv Jahar from New York. So you
Please.
call this Medina class, what, 001 or 011?
It's a 011.
So
This is.
you think the ostial LAD is involved?
See, it's around 70% disease across the LAD, and then we are not sure about, though the mid LAD do have a significant lesion. It's a bifurcation point over there. And can we have this is the first view, second view. Okay, and this is, you can very well see the bifurcation is bifurcation site of the left main. There is the lesion, and therefore it's 111. But then there is a need to assess the LAD, which is around 70%. Ostial LCS, of course, is very significant.
Okay, Rajesh, you are angiographically definitely saying the ostial lesion of these LAD and SARC. I believe you are a man of the IVAS, so definitely I may extend possibly distal LMC as expected.
Okay.
The question is how we're going to proceed. Are you going to proceed with a two-stent strategy, which I assume you will? What is your plan? What is the panel?
So the plan is go to the previous view, first view. See over here. See, LAD doesn't seem to be so significant. If you see the proximal LAD, it's of course calcified, but the lesion is around 70%. Ostial LCX is of course significant. You do have a proximal LCX and also the distal LCX. The stent is there, which of course is patent. So the plan is to have an assessment of the LAD, whether it is significant, and then to proceed accordingly. Of course, the LCX can also be assessed functionally and also with the image guidance to look for. We already do an proximal LCX stent, which has been deployed in 2009, and the distal LCX, of course, in 2016.
So Rajesh, you're going to do IFR or FFR of the proximal LAD?
Absolutely right. So let's have the functional assessment. Can we go to next view, please? So you can very well appreciate there is the calcification across the ostium to distal LAD in this fluoroscopic view. we have a wire across the left circumflex, and this is the FFR wire in the aorta. Next view, please. And this is the FFR across the left circumflex. Can you demonstrate the FFR across the left circumflex, Nikhil? Baseline and post-adenosine. This is what post-adenosine and baseline. So we had now FFR across the left circumflex, ostium 0.89, which dropped down to 0.77, 0.73 following the adenosine. So it's a significant ostial left circumflex lesion, which is there. Angiographically, sometimes it's very difficult to assess whether the LCX ostial lesion is significant or not, and therefore we went ahead and did the FFR across the LCX, and which turned out to be significant. Meanwhile, as we have taken the FFR for the LCX, we have taken the FFR of the LAD as well. So can you show the FFR of the LAD, which is baseline 0.90, and post-adenosine is 0.76. So this is about the FFR. Next view. Okay. So this is what the functional assessment, and which is very much suggestive that we are dealing with a significant LAD and also the left circumflex. Any comment?
You know, the one area where I'm always wrong when I do IFR or FFR is the LAD. For whatever reason, when I think something is going to be non-significant, this one I would have thought would be significant because it's long and diffuse, and just the length of it would probably make it significant. But I've had many situations where I thought a FFR would be negative and it was positive in the LAD.
Not only that, the FFR is more predictive, and in view of that, the FFR predict the maze and TLR better way than the IFR. Rajesh, do you believe or not? There is article is there.
Yes. See, the sensitivity of the FFR is FFR basically the gold standard. In case you do have the IFR, which is say less than 0.86, it's fine. More than, in case it's in the gray zone, and that's the time one has to go ahead for the FFR. We have already done the FFR following intracoronary adenosine across both left circumflex and LAD, and it turned out to be significant.
Dr. Rajesh, Dr. Girish here.
Hi, Girish.
There are some technical aspects. What is the guide which you have chosen? And the wires were...
This is what we have taken is it's a 7F femoral sheath, and it's a long sheath. When I did the LCX PCI in 2016, there were tortuosity and difficulty in cannulating the left corona. Therefore, we have taken the long sheath at that moment of time, and therefore at this moment also we have taken the long sheath. And this angiogram we have already assessed this around 3 days back, and next view. So this is the diagnostic angiogram which we did 3 days back, where we assessed both the LAD and the LCX, and today we have taken for the PCI.
I think Dr. Rajesh,
this is not the view at present. This is transradial 6F, and then we had an assessment of the left main bifurcation around 3 days back.
I think, Dr. Rajesh, I think you have long left main and LAD lesion which is very long, and LCX ostium lesion is very focal actually. So I think I expect that you will do a good job first for the LAD, and then I think we can decide about the upfront strategy for the ostial circumflex. What is your opinion on this?
Okay, so this is the first angiographic view today which we have taken. You can very well see the long sheath in the aorta, and then it's a EBU 7F guide across it. And before that, we have already done the OCT across both LCX and the LAD. So can you show the OCT across the left circumflex? So this is the, can you display the OCT? Big screen, please. Okay, so this is the OCT across the left circumflex, and you can very well appreciate distally the stent is okay. Proximally, the stent is underexpanded. It's a 3 millimeter stent which is having the dimension of 2.5. Nikhil, how much is the dimension over here? 2.4, so it's basically under expanded stent which was deployed in 2009. And then this is the ostial, which is very significant ostial LCX, having the area of 1.65 millimeter square. Nikhil, what is the distance between the ostium of the LCX and the stent across the proximal LCX?
It's 10 millimeters maybe?
Both
So it's a
mechanical-
3
mechanical.
points.
Rajesh,
Yes, please.
yes, there is both mechanical and biological factor responsible for the ostial restenosis.
Absolutely right.
Yes.
See, the distance between the stent edge in the proximal LCX and the ostium is 3 millimeter. So it's a part of, say, in-segment restenosis, I would say, but definitely there is a disease which is focal at the ostium of the left circumflex. And this is the left main, which is calcified. You can very well appreciate some calcified plaque across the left main. Can you again demonstrate the left main? We do on the left. So these are the left main. See, you see the calcified nodule over there at the left main.
Yeah, there's about 4 o'clock, 4 or 5 o'clock.
Absolutely right. 4 o'clock, and the left main, which is again calcified. Left main dimension over here is 4.5. The proximal LCX is 3 millimeter. Ostium again is 3 millimeter in dimension. Can you show the LAD OCT run as well?
The calcified nodules of LMCA, whether eruptive or non-eruptive, can you predict on the OCT basis?
Yes, it can be very well predicted, and here it is a non-eruptive calcified nodule in the left main, and this is about the OCT run across the LAD.
Rajesh, in the interest of time, because we have to go to another case also, what is your strategy now?
My strategy is to go ahead and put the stent across, say, left main to LAD crossover. Focal LCX lesion can be taken care by, say, balloon dilatation, and thereafter let me see what the result is across the left circumflex, and then to decide whether to put the stent or what next.
So you would do just a regular non-compliant balloon into the circumflex, not a DCB or cutting balloon.
Let's go ahead and discuss it out, how to proceed further. Meanwhile, as it is calcified lesion across the LAD, 360-degree arc of calcification is there, which can be very well appreciated. Minimal luminal area. Can you demonstrate, Nikhil, what's the minimal luminal area? It's a 1.95 in the mid-LAD. Proximally, it's the LAD, which is very much calcified with the area which is on the lower side. And of course the left main, which is diseased. So my plan is to go ahead left main to LAD, cross our stenting, and see about how to proceed further for a focal lesion across the ostial left circumflex.
What is the expected length of the LAD lesion from the ostium?
Nikhil, how much is the length? Can you demonstrate ostial left main to mid LAD? This is going to be around 60 millimeter. 55.
The mid LED is what size again?
Sorry?
The mid LED, the MLA is what?
Mid LED MLA. Can you show the minimal 1.95?
Okay. Very significant.
Yeah, by the definition criteria, I think, will it fit into upfront two stent strategy?
See, with the focal, simple bifurcation left main, this can be taken care by the one stent strategy. And you do an in-stent restenosis, or rather in-segment restenosis of the ostial LCX, so that can be treated with regulating balloon.
I think what we feel is maybe upfront cutting balloon to the circumflex ostia, and maybe DEB later on after the stent.
See here if you see the OCT across the left circumflex, there is no calcium. Of course, there is the calcium across the LAD and also the left main. So let me see how the result is going to be after balloon dilatation, and if required, we can go ahead and do the cutting balloon across the ostial LCX as well.
But Rajesh, your strategy though is a provisional single stent strategy right now.
Absolutely right.
And you may change, but right now, because having a plan obviously is a very important, and so you'll stent, you'll first double wire, you'll balloon the circumflex, then you'll stent the LAD, and then provisionally deal with the circumflex again. Is that true?
Absolutely right. So you can proceed for another case, and meanwhile I do some work over here, and then you can revert me back. Is it okay?
Rajesh, I believe that is little better. We have to preparation of the ostium also by the cutting balloon prior to the provisional stenting LED.
Okay.
Otherwise, great difficulty will be arise later.
Right. We do an 360 arc of calcification across the LED. Any comment about other than cutting balloon rotablation?
There were some calcium specs in the mid and proximal LED, so that you can have a look again carefully and then take a decision.
You know, I think I would, I always, if I think rotoblader or orbital, I always do it because I think the regret is very painful. So I would argue that you should probably debulk it with a rotational atherectomy of the LED. But you know, so on the panel, what do the people think down the hall over here?
Dr. Nirmal Kumar, what is your thought? Dr. Nirmal Kumar, what is your thought of the case?
I think first we should do the good work for the circumflex ostium. First we should do the good work for the circumflex ostium. Use the cutting
Can we go to the...
if it is possible, drug-coated balloon, and then do the stenting across the LMC, because LMC is also a critical lesion in one view. So you can go across the LMC to the circumflex.
Next.
So Raj, what did you do?
Okay, next. So from here we started, we extend the rotafloppy wire across the distal LED and did the rotablation with the 1.5 bar. Next. And this is after the rotablation. Next. There is one major branch diagonal, the first one, and then the other one is the disease distally and also the proximally. Next. We did wire that particular branch, the proximal one, which is a bigger one, with another wire and also a wire across the left circumflex following the rotablation. Next. And here this is 2.520 NC balloon across the distal LED where the calcium is less than 180 degree. Next.
You know, I love the fact that you did the ballooning after the roto.
Absolutely right.
A lot of my colleagues will just roto and then try to stent it, and even then they can't get full expansion, and then it causes a huge mess. So always balloon before you stent.
Rota balloon or rota cut, this is very ideal indication.
Okay. So it's a 2.5 distally. Next view, please. And these are the same balloon 2.5 across the D1, which is a big branch. We went up to 8 atmosphere, a slow inflation and the deflation. Don't want to have a dissection across the ostium of the D1. Next. So this is what good flow across all the two branches, D1 and D2, and of course the LED. Next. And then this is the cutting balloon, 3 millimeter. Our proximal LED is of 3.5. Here we have taken the 3 millimeter cutting balloon. That's from the Boston, Wolverine from the Boston. Next view. Next view. This is proximal LED cutting balloon. Next view. Next view. Left main to LED cutting balloon. So here is what we have achieved after having the cutting balloon across the left main to the LED. Next view, we dilated the left circumflex ostium with a 2.5 balloon. Next view. And this is the 3 millimeter NC balloon across the left circumflex, been inflated at 18 atmosphere. Good dilatation, you can very well appreciate there is no residual ostial stenosis of the left circumflex. Next.
Did you do any cutting balloon to the left circumflex?
No, we did not. We did not, as there was no calcium across the ostium of the left circumflex. It's a tight fibrotic stenosis, and therefore we didn't go ahead for the cutting balloon dilatation across the ostial LCX.
LED distal part, there is some lesion. I think it is not dilated. Do you like to put the stent at the adjacent to the D1? Adjacent to the D1 there is.
So distal to the balloon dilatation, there is some disease. Next view. And this is what the ostial LCX flow after having the balloon dilatation. Next view. And after the NTG, there is an improvement in the distal LED flow. and you can very well appreciate there is a lesion which is after the origin of the D1 and D2, extending up to say 20 or 24 millimeter. Next. And this is 328 as the distal reference diameter was a 3 millimeter, 328 giant alpine across mid to distal LAD. We just took care of that to cover both the D1 and D2 with a single stent without any overlapping with the second stent which we are intended to put from left main to LAD. So this is what 328 across mid to distal LAD. Next. And the residual length is around 28.
Raj, did you think
Yes,
maybe doing OCT here versus IVUS because there's so much calcium?
No, here we have not done any imaging at this moment of time because we were aware of what the size of vessel, how much calcium is. We have done the debulking with the rotablation, followed by the cutting balloon, and therefore we thought let's go ahead and put the stent and then do the post stenting imaging to look for what result we have achieved about.
Dr. Rajesh,
Yes,
you are managing 3 wires now, and now you are putting stent across the left main to LAD. Would you like to see that first bifurcation, and you want to remove the diagonal wire because you are trying to jail 2 wires? So because how you are managing these 3 wires, that also is very important.
Absolutely.
Or prior to that, you can treat the D1 if possible.
A good point to discuss over here, whenever there is a calcified lesion and you have a jailed wire which is of so a great length, there can be a problem in removing it. So next view. So now we just position the left main to the LAD stand. Next view, and here if you see, we have removed the diagonal wire before putting the stand from left main to LAD. As the flow across the D1 was good, we could safely remove the wire and then went ahead with the stenting of left main to LAD. Next view, please. And this is 3.533 giant alpine stand from the left main to the LAD. We have a LAD reference diameter which is 3.5 proximally, and also the ostium left main is of 4.5. And this is what the result is. Overlapping is there just proximal to the D1 origin. There is a good flow across D1 and D2, and of course the LAD. There was some lesion which
Rajesh,
got
are you going to
improved.
image now the ostial LAD and the left main, or are you going to wait?
Sorry?
Are you going to image the left main and the LAD?
No, we have already put the stent from left main to LAD at this point of time, and this is post-stenting.
Right, but my point is that in my practice, I will image 100% of patients who have left main because I'm never sure if I've expanded that stent completely. It looks underexpanded in the distal left main. I'm just wondering if it would be better to image it and make sure.
Okay, we already...
Some narrowing is there in the middle of the sapped up distal.
Absolutely.
And I think LCX should be imagined before going for the angioplasty stent across the LMCA. Because after that, LCX imaging is difficult because still some haziness is there in the ostium.
You know, I was talking more about the LAD into the left main imaging, and not the circumflex. The ostial circumflex is always very difficult to get a good result with just a balloon. It's more fibrotic than you think, and I just think you're going to have to either do a cutting balloon or something else there. But in the meantime, we're going to go to our lightning talk, and we'll come back to you in about 4 minutes.
Yeah, this point about the circumflex ostium, the concern is that it has been addressed with only an NC balloon and not with a cutting balloon.
That's what I mean.
Suppose it closes off after the pot. So I think initially it should have been addressed with a cutting balloon or at least a scoring balloon. What do you?
100%.
I think, Dr. Rajesh, what you can do is, you can rewire the circumflex and take a OCT picture from LMCA to LAD to LMCA and circumflex to LMCA, and then take appropriate selection.
See, this result what you are seeing over there is just after putting the stent across left main to LAD and the mid LAD. So can you go to the next view? Next view. And here is the post dilatation of the LAD with the 3 millimeter NC distally. Next. And this is 3.5, and then we had a port with 4.5 across the left main. Next. Next. And this is what is there after having a dilatation of left main to LAD with 3 distally, 3.5 proximally, and 4.5 in the left main as a port. Next view. And then then we rewire the left circumflex. Next, dilated with 2.5 millimeter balloon. Next, and this is 3 into 20 magic touch drug-eluting balloon, which in the two session, 30 seconds each, we have inflated across the ostium of the left circumflex. Next, and this is what the result is at present, and now we have to proceed further.
Okay, so
I think imaging would help you now.
So now it's the imaging time. Let me go ahead and do the imaging across both left main to LAD and also left main to LCX and see how much is the result across the ostium.
Now.
So
What have you done now?
I think you're planning for a tap.
okay,
Right?
so we have done the OCT. Can you show the OCT then, please? First for the LCX.
This should be interesting.
Stand lagana. Can you have a big screen for the OCT? Yeah. Okay, so this is the OCT run across left nickel, left circumflex. So this is after say 3 millimeter NC balloon followed by a drug-eluting balloon, and we do have a residual ostial stenosis which is having the minimum area 1.82 despite angiographically it's looking nice, but then there is a residual stenosis. Left main stent is
You deployed upfront DCB, no?
Yes, this is after the drug-eluting balloon, magic touch, which is 3 millimeter for 60 seconds in total. And can you show the OCT on the LED as well?
At which atmospheric pressure? 6?
It's around 10 atmospheric pressure.
Okay.
Raj, we have about a minute left maximum.
Okay, fine. So let me finish it off completely. Okay, so can you see the OCT run? Kindly display the OCT run of the LED. Yes. 8, 10. Kitna? 12. Very nice. Inflate. Negative. Inflate. 18.
I think you can show us the live what you are doing. We can see the OCT.
Okay. Just a minute. So what, even after having a balloon dilatation with a drug-eluting balloon of 3 millimeter, we didn't have a favorable acceptable result across the ostial LCX, and therefore decided to go ahead and do the tap stenting. And then we choose as the OCT, we didn't do the kissing balloon at this moment of time before doing the OCT, and therefore we decided to go ahead and put a 3.5 18 millimeter stent across the ostial LCX as a tap technique. And then it's a 4 millimeter balloon as the size of the ostial to proximal LAD is around 3.87, so it's a 4 millimeter balloon dilatation, and this is what we do have the result across.
Can we have the live pictures now, please?
Yes. So
very good
we have removed the stent balloon, and 4 millimeter balloon is there across the left main to LAD. Let me take the 3.5 NC balloon and the final kissing followed by port. So that's the plan. And this is the angiogram before doing the kissing balloon after putting a stent across the ostial LCX. So
it goes back to Raj, it goes back to my original point. The ostium of the circumflex is so hard to just balloon. It never looks right. I appreciate the fact that you IVUS did or imaged it. I mean, OCT did, sorry. And, you know, and then you saw that the MLA was really low and you put a stent in. So that's a great point. I think we're going to have to end it here. Do you agree, sir?
Yes, actually some narrowing on the near the angle is small.
What we are going to do is 3.5 NC across the LCX and 4 millimeter is already there in C2. So kissing balloon dilatation 18 individual followed by 12 atmosphere and to be followed by a pot with say 4.5 or 5 millimeter depending on the dimension of the left main. So that's what, and to be followed by the final OCT across both LAD and LCX.
Okay, very acceptable result.
So according to your OCT right now, so what is the size you would be using for pot, left main pot?
Pot, Nikhil, can you show the size of the left main? How much is the size?
Is it 4.5 or 5?
Let us reassess it. It's 4.5, so it's going to be say 4.5 pot. And this is what 3.5 balloon across the LCA. So let me go ahead and inflate it. 12, 14, 18,
okay.
Negative. So negative. And then it's the LAD, inflate.
Can we do an NC balloon after a DEB, sir? I need to.
18. So
the question
negative.
Is after DEB, NC.
After the DSA, you are inflating the NC balloon, or it is another drug-eluting balloon? Because
no,
drugs
it's
are
an NC
lost.
balloon. 12. See, now the question is, we have already put a drug-eluting stent over there. 12. So this is the kissing balloon with the 4 across the LAD, 3.5 across the LCX, negative. And now we are going to do the pot with 4.5, the final pot across the left main. Any comment?
Till now, I think it's looking good. I think we would be interested to see the OCT after the pot.
Okay.
Another 2 minutes to you, Dr. Rajesh.
Fine. So 4.58 balloon for the pot, please.
Any comments from the panelists?
We have dedicated pot balloons nowadays available, and we are using plain non-compliant balloons most of the time for pot. Do you have any experience of using this dedicated pot versus what non-compliant balloon? Is that make any difference as such? We don't have.
No, you are right. There are certain dedicated pot balloon, but as in routine, we are using it from the Abbott and Boston with the satisfactory result. And as we have already covered the left main ostium, I don't feel like there is any problem in case our balloon is going to hang in the aorta. That's what.
So this side
Rajesh,
of the room,
you have deployed, actually you have done the kissing balloon SARC and the LAD after the DEB implantation. But question of that, effect of the drug will be lost in the circumflex.
See, now the question is, we thought angiographically it's a good result, but then there is a residual stenosis across the ostial LCA, which was very significant, and therefore we have went ahead and put a drug-eluting stent. So now there is a question that you have put sirolimus drug over there with the magic touch, and now it's everolimus drug from the drug-eluting stent. So is it going to have some problem in the future with the two drugs which are there in C2 at the ostium of the LCX? I am not sure how this patient is going to behave on follow-up with the two drugs being there at the ostium of the LCX.
we were just wondering whether a two-stent strategy upfront would have been a good choice here, because I do think this ostial circumflex needs to be addressed, and would have been easier to address it right at the beginning. You could do a culotte or a mini culotte, and that might have been a better strategy, because many cases we've done like this, left suboptimal circumflex and ended up 6 months later with 90% ostial circumflex symptomatic.
Yeah, no, again, I would go with him. I would agree with that. And culotte versus decay crash. Why did you prefer culotte?
this is not clot. This is tap technique, okay?
Sir, we are discussing with the panelists.
Yes.
Okay, sorry.
TAP is not a good result compared to the culotte.
But a mini
Again,
culotte would give
cross
you
also.
minimum of double layering in the left main. So keep very little, 1 or 2 strands in the left main from the, so if the first one was left main to circumflex, and keep minimal length in the left main, and I think because of that angulation, there's very little chance that you will not be able to address the LAD afterwards.
I think you
that would be one strategy, but DK crush is good.
No, you're correct.
I think that if you look at the data though, right, the DK crush is probably, if you're going to do a 2-stent strategy in this scenario, I would argue that DK crush is probably the best option. Provisional, we could argue provisional, but this is a large circumflex, so I don't think so. But anyway, in the interest of time, I think we're now way over. I think we'll end the session.
If you do have the time, let me go ahead and put the OCT across left main to LCX and later on the LAD. So you just have a look on the run for the left main to LCX and...
Raj, I think we're going to have to leave.
Okay, fine.
So it looks very nice, terrific job. And I love the fact that you had a plan and a backup plan at the same time. So the plan was, whatever it was, and then it didn't really work, and you did the tap, and I think that was a great idea. So congratulations and a great job.
Thank you.
So,
thank you.
Rajesh, I'm very thankful to you and to your teams. As a whole, they have done a wonderful job done by us. And both the operator, both Patna and Chandigarh were excellent. Thank you very much indeed.
Thank you very much. My pleasure.